Good morning. Let's get started. So first I just wanted to remind you guys that the exam review is tonight. Katie's going to be running it. Yay. So 4 to 6 p.m. on Zoom. The link will be in the announcement. That's a question, sorry. Yes. Yeah, okay. Okay, so apparently there's just notices everywhere. So yeah, not only did she do the exam review, but she did some really nice study guides and stuff to use as well. Yes?
Will it be recorded?
It will be recorded, yes. We'll try to get that up for Friday.
Awesome.
Okay, so yesterday we started on digestion. We talked about food. We talked about being able to break it down so that we could use it. And now we're going to start walking through the sections of our digestive tract, starting, of course, with mouth. We're going to talk a little bit about how we have an epithelial layer that just runs the entire GI system. So it's a single layer. It's continuous throughout the system. We're going to talk about the swallowing reflex, how we get the food from our mouth into our esophagus, and then we can move that down to our stomach. In between the esophagus and the stomach is going to be the esophageal sphincter, which helps to keep the stuff in the stomach. Okay, that's a very acidic. It's got a lot of enzymes in it. You don't want it to come back up into the esophagus, so you've got a sphincter there that hopefully is working properly and will keep that food down. Once we get into the stomach itself, we'll go through the different layers. We call them tunics, and we know most of this with just new terms that we have to use, new titles for them. So mucosa is just the epithelial layer. Submucosa below that is going to be the connective tissue layer. And then we'll have smooth muscle here as well, but we're going to have 3 layers now. We're going to have them in every direction, longitudinal, circular, and oblique, so that you can really crunch the stomach up in every direction and really get that food moving around. And then outside of that, we'll have a serosal layer. It's mesothelium. So this is the same thing we've talked about, that balloon that you grow the organs into. That was pericardium on the heart, pleura on the lungs. Here it's peritoneum. Okay. But it's still going to have that same visceral and parietal layers. Then within the mucosa of the stomach itself, we'll have gastric pits. And these are going to be the cells that are doing a lot of excretion of the enzymes that we need. The first one is going to be goblet cells producing mucus. So when we have this high acidity in our stomach, we need to protect our own cells from that acid. And so we put a thin layer of mucus over everything. Goblet cells are the ones that are going to create that mucus for us. Chief cells are releasing pepsinogen, and pepsinogen is an inactive enzyme. That's the O-gen on it. And that's because most of our digestive enzymes are very dangerous. They're meant to digest proteins, amino acids, lipids, the things our body is made of. So we release them as inactive forms and then activate them when they're at the proper place so they don't just start digesting us. Parietal cells are going to be the ones that are creating that hydrogen ion that create that low pH, that acidity in the stomach. And we're going to use that acidity as how we're going to activate the pepsinogen into pepsin. G cells and enterochromaffin cells are both going to be releasing hormones. G cells are gastrin. That one's nice, it makes sense, G and gastrin. And then we've got these horrid things, ECL cells or enterochromaffin-like cells. Those are going to be releasing histamine. So remember that when we talked about histamine before, we've always said mast cells. You're just going to have to remember ECL now. I wish I could change it, but I don't have that authority. So those parietal cells that are releasing hydrogen ion can be regulated based on triggers like eating. When we need more acid in our stomach, we can upregulate that by binding either gastrin or histamine coming from those gastric pits, or also acetylcholine that's coming from the autonomic system. So parasympathetic is going to be controlling our digestive, and acetylcholine is going to be released from that postganglionic neuron and then bind to a muscarinic receptor. So we'll look at all of that. But first I want to start with exocrine because I didn't quite finish it yesterday. All right, so we said that exocrine glands, unlike endocrine glands, are going to release into a duct, and that duct goes out. Exocrine gland. Okay, so this is into duct. And I said the primary exocrine glands were salivary, sweat, mammillary, but we're not going to cover that one, and then pancreatic. And they all have their specific purpose. They'll all have something special about them, but they have the same basic foundation. where they're going to have this duct. And it's just a single layer of epithelium. And that epithelium is sitting on a basal lamina. And each portion of this duct has a different purpose, different name. So up here we had our surface epithelium. As we started moving down into this duct, these were duct cells. And then the cells at the bottom, or you can also call them secretory cells. The main component of all of these is going to be water. And to get that water into the duct, we have to trick it by using sodium and chloride. So we move sodium across the cell, we move chloride across the cell, and that creates a gradient for this water to follow. But the water is going to move in the cellular route. So just like we saw in the proximal convoluted tubule, the gradient out here in the duct, in the lumen, is going to draw that water to actually twist and turn its way through those tight junctions and pass between the cells to get into that duct. So this is paracellular. But then we're going to switch them out, put these sodium and chlorides back through these duct cells, and replace them with bicarbonate and potassium. And the one thing I didn't get to yesterday was talking about how these chloride channels are actually very important. These particular channels are called CFTRs, cystic fibrosis transmembrane receptors. Okay, we're not just using them here in these exocrine glands, although they're obviously here, they're important, but they're also in the lungs and a couple of other places. These are the receptors that if there's a mutation, you'll end up with cystic fibrosis, the disease. It's more important in the lungs because the movement of chloride through these CFTR channels is going to cause a gradient for water to follow, and if the channels don't work, then the mucus doesn't get watered down, so they get really, really thick mucus, they can't move. Okay? But the interesting part is that you can test for cystic fibrosis by testing sweat glands. You just take their sweat and test how much chloride do they have in it. Because under normal conditions of an exocrine gland, you're trying to bring that chloride back. You swapped it out for your bicarbonate and potassium. If under normal resting conditions, any minor sweat that they have has high levels of chloride, it suggests that the CFTRs aren't working. Okay, and that's enough for a diagnosis. But talking now about salivary glands, we can say that the salivary glands are going to be comprised of, or the saliva itself is comprised of this water that we've put through, the bicarbonate, potassium, and then specifically for saliva, we're also going to create an enzyme or release an enzyme called amylase. So remember, anytime you see ACE, that just means an enzyme. And amyl is something similar to what we talked about yesterday. We talked about amylose and we talked about amylopectin. Both of them were starches. So amylase is an enzyme that breaks down starches. So this means we are actually doing a small amount of chemical digestion in our mouth. And that's why when you put something like a cracker or bread or some other form of starch in your mouth, you'll start to kind of feel it dissolve a little bit. You're already working on it with your saliva. But most of the rest of your chemical digestion is going to be in the stomach and small intestine. So questions on exocrine or salivary gland? Nope. Let's start working on the mouth. Okay, I will just apologize in advance. I've tried, I promise. I practiced. The mouth is just, it's beyond me. So there's a lip. There's a lip. Here's some teeth. I don't do pumpkin carvings either. I'd probably scare the children. And then we're going to have throat to esophagus. I'm going to label that so we know. That's mouth, or it's meant to be mouth. Sorry. This is esophagus. You know, I will tell you, if Dr. Walburn was teaching this, it would just be this. This is how he does mouth. Okay, so that's an improvement. All right, so mouth. We've talked about now being able to salivate. We create this secretion through our salivary glands. We do some chemical digestion here. We know we're doing mechanical digestion through moving this with our teeth, chewing it, gnawing it. And we do a lot of motility. We move this food around with our tongue. And eventually we're going to move it towards the back of our mouth. Now if you take your tongue and you push it up, you'll feel a hard palate. It's really hard up there. But beyond that hard palate is a soft palate. Most of you, unless you have a really long tongue, probably can't touch it. And please don't try. You can actually swallow your tongue. But once you've washed your hands, you can take your finger and go past, as long as you don't have a really strong gag reflex, go past your hard palate and you can feel a soft spot back there. This is soft palate. And I meant to look this up. I still don't know how to spell palate. Okay, I'm going to spell it like it's a wooden board. I don't know. Okay. Palais. We don't knock you on spelling, so don't worry about it. Probably won't put that in a fill in the blank now just because I'm humiliated. All right, so that's your soft palate. It's very sensitive to pressure. So this is a trigger, you know, food pushing here. What?
P-A-L-A-T-E.
A-T-E. Oh, yeah. Okay. Thank you. Palate. That looks better. Okay, so it's not wooden, it's very soft. Food touching here triggers the swallow reflex. Okay. And we've all done this even accidentally. We might be chewing gum, we might be eating food, we're just not paying enough attention, we move it a little too far back, it hits the soft palate, and it starts to go down. And you're like, wait, I wasn't ready for that. But there's good news, because at the top portion of your esophagus, this top 1/3, this is skeletal muscle. Skeletal muscle is under conscious control. So we could still rescue this. You can actually cough up stuff if it hasn't gone down too far yet. Once it gets past this point, though, you're in trouble. It's gone. Unless your body decides to kick it out, there's nothing you can do about it. Because from here on out, this smooth muscle is going to be doing that peristalsis we mentioned, where you have that rhythmic wave of contraction that pushes food down. So this is peristalsis. And we do that now throughout the rest of the digestive tract. So if we had chocolate chip Okay, and I decide to keep swallowing it. Now we're down here to smooth muscle. The smooth muscle will contract behind it and stay relaxed directly in front of it to push it further. And then it's just a rhythmic wave where it's going to continue to contract behind it and push it down. And I forgot to draw the epithelium in. So we've got this continuous layer of epithelium running through our entire GI tract. Oops. So that's esophagus. That's really all we're going to say about it. It's just a motility thing. And just recognize that you have some conscious control in the top portion, but below that, smooth muscle. From here, we're going to move into the stomach. Okay. Stomach. And this epithelial layer is just going to continue all the way down. Yeah. But before we actually get into the stomach, we're going to have smooth muscle that runs around this junction between the esophagus and the stomach. And this is called the esophageal sphincter. You may have heard this previously as cardiac sphincter, and that's fine too. I like esophageal because it tells you where it's at. But this is the sphincter that is going to allow food to pass from the esophagus into the stomach, but prevent it from coming back up once it's there, hopefully.
So, if that doesn't function right, is that just acid reflux?
Yes. So if this is too weak, or as we get older, this can start to weaken, you can start getting some of that food that comes back up. If it starts coming back up through this esophageal sphincter, it is gastric reflux. Okay? And this is bad. Okay, so gastric reflux is going to be all of that stomach contents, that acid, those enzymes. In the stomach, we have mucus that's meant to protect the cells from both the acid and the enzymes. In the esophagus, we don't. Okay, so there's no protection. You start bringing stomach contents back up, and you're going to eat those cells. You'll destroy them. You'll replace them. But the problem with doing that is every time we turn a cell over, we create new cells and make new DNA, we run the risk of putting mutations in. So the faster your turnover, the more likely you're going to have mutations that could lead to cancer. So people who have chronic gastric reflux often get esophageal cancer. Okay, so if you have reflux, make sure you get it treated. There are treatments. All right, so down into the stomach now we can talk about all the different layers. And don't worry, I'll show you a picture of this too. But this first layer is just the epithelium, but we're going to call that mucosa. I didn't show it because of course I can't draw it, but it is actually in folds, and we call those folds rugae. Okay. That's going to increase the surface area of the stomach, and it's going to give it more room for stretch. So when we eat a lot of food, we actually stretch our stomach out. That folding will be able to stretch out. In addition, just below this, and of course this is basal lamina, just below the mucosa, we have the submucosa. I'm going to do it in red. Why not? And the submucosa is connective tissue. So when we talked about skin, and we talked about having the epidermis and the dermis, we said the epidermis was an epithelial layer, the dermis was a connective tissue layer. Same setup here. We've got an epithelial layer and then a connective tissue layer. And in the connective tissue layer is where we're going to have all of our blood vessels, we're going to have our nerves, We're going to have extracellular proteins like elastin and collagen. And that elastin is also going to help with being able to stretch your stomach when you need to. So blood vessel, nerve, and I'll just say elastin. I didn't leave myself enough room. All right, so the next layer is going to be muscle. Oh, I probably should have done muscle in red. Oh well, muscle's going to be green. Smooth muscle's green. I have it up there as green. That's perfect. Okay, so you're going to have your first layers longitudinal. That means it just follows the shape of the stomach itself. Then you're going to have a circular layer that wraps around the stomach. And then you have one that's oblique, it goes diagonal. So those are your smooth muscle layers. Longitudinal, circular, and oblique. Again, the whole purpose of that is just to be able to move your stomach in every direction. That's going to help with mechanical digestion, but it's also going to help take all of the acid and all the enzymes that you're putting into the stomach and turn it around so that all the food particles are exposed to all the different enzymes. And then finally, we said there is a serosal layer. Okay, and that's a mesothelium, so it's that balloon-like structure that you grow your organs into. Oops. And here we just call that peritoneum. And by here, I mean the abdomen. Okay, so every organ in the abdomen except the kidneys is actually covered by peritoneum. You may have sometimes heard the kidneys referred to as retroperitoneal, and that just means it's behind the peritoneum because it's at your back. And just like all of our mesothelium, we do have two layers. So you'll have an inner layer that's going to be the visceral layer directly on the body, the organ wall, and then a parietal layer that's attached to the body wall, the abdominal wall. Okay. Sorry, that got a little hectic. Yes.
So, in regard to the serosa and peritoneum, is like the serosa just the part, the peritoneum that covers the stomach, or like is it just the exact same thing, just different names?
No, it's just like mesothelium is the cell type, just like epithelium. If you were to talk about epidermis, you could say that epidermis is an epithelium, and we could call that a mucosal layer. So this is a peritoneum. It's just made of mesothelial cells, and here we're calling that layer serosa. Yeah. Anything else? All right, I'm going to show you pictures. Go ahead.
Sorry, which one was connected to the smooth muscle of the serosa?
Oh, the serosa, I'm sorry. Visceral is always going to be the one that's attached directly to the organ.
Oh,
Okay, and then parietal is the one that goes to a body wall.
thank you.
Yeah. Okay. No, we did that already. Oh, look. Well. Okay, so that's tripe. This is rugae in a cow. Our rugae does not look quite like this. Their digestive system's kind of weird, honestly. It's a lot different than ours. But it does give you a sense of how you're going to fold that epithelium and increase the surface area. This is a human human stomach, and it's trying to show you the different layers, like of smooth muscle. So you can see longitudinal, circular, sorry, that's longitudinal. circular, oblique. But I like this picture specifically because it shows you the epithelium, and that's the folds, the rugae. So it's not as pretty, actually, as the tripe. If we take a section out and we look at the stack, this is the epithelial layer connected to the lumen of the stomach, and you can see the folds, but you can also really see these gastric pits that run down the entire length of that mucosa. It's just still an epithelial layer that's diving deep. So those cells are the ones that are going to be releasing all of the important stuff into our stomach. Right below that is our mucosal layer. That has the blood vessels and the nerves, and then you can see the muscle layers facing 3 different directions, and then serosa, your peritoneum on the outside. Okay, and this is really more for Abby than anything else. You don't have to know any of that, but this is a cross section where you can see. Abby likes to describe the entire GI system as a donut, where the inside is the lumen, and this fun part here is the epithelium, right? So if you take a cross section, this actually does look like a donut, at least in this picture. I still think you probably drew this anonymously. All right, so hopefully that gave you a better idea of where we're actually at with this. There we go. But now we're going to move to gastric pit. And I just want to show you again that this was our mucosal layer. But a gastric pit is just, that doesn't help, I'm sorry. But it's just the epithelium that dives deep. So it's still epithelium that's just traveling down into a pit. Okay, so gastric pit. Okay, this is going to look remarkably like an exocrine gland, because it is pretty much the same structure, just deeper. Single cell, single layer of epithelium. And we can orient this. We could say that the outer side is the basal lamina. So I'll hash that. Okay, so this is still mucosa, and below this would be submucosa. That means that this is the lumen where the apical side of these cells are facing. And this is the drum, if you will, of the stomach. If you make something in the pit and you put it out here in the lumen, you're just in the main portion of your stomach. Okay, so we want to start first with goblet cells. These are going to be towards the top of your gastric pit. And these goblet cells are the ones that are making your mucus. That mucus, again, is just meant to protect your epithelium from the acid that's in the lumen. So hopefully it makes sense that this mucus needs to be released into the lumen. Okay, so mucus will be out here, and that means it's going out the apical side. Excuse me. Second cell we mentioned was the chief cells. I'll do those here. Okay, I'm drawing these in randomly. There are more than one of each of these. And they do have some orientation. They really do have goblet cells up higher, but it's not exact, and you don't need to know that. Just recognize the different cells within the gastric pit and where they're secreting and what they're secreting. So these chief cells are going to be secreting pepsinogen. And again, that's the inactive form. But we want to put this into the lumen because we need this to be able to break down the proteins that we've eaten. So this is going to go across the apical side. And then once it's out in that lumen, it's going to be in a very acidic environment, and that's very helpful because pepsinogen will convert to pepsin with exposure to acid. A little more complicated, but that's good for now. So a reminder too that pepsin is a proteolytic enzyme. And that might not be a reminder, I might not have told you that yet. Proteo just means protein, lytic means to lyse, again. So we have talked about proteolytic when we talked about lysozymes. Here, this is going to be breaking down the proteins that we're eating. Green, blue, I guess we do red. Red for parietal cells. So these parietal cells are the ones that are responsible for hydrogen ions. Now, those hydrogen ions are going to cause a low pH. That, again, is something we need in the lumen. So this is going across the apical side. And when we put all of this hydrogen in here, we're actually going to bring the concentration of hydrogen ions so high that our pH is going to be about 2.0. Okay, that is very, very acidic, very high concentration of hydrogen ions. The question is, where are we getting all these hydrogen ions to be able to pump out into the stomach? So let's take a closer look at the parietal cell. All right. So this is the basal lamina or basilar side. And this is our lumen. We can create hydrogen ion in the cell by using our carbonic anhydrase buffer system, the one that we talked about in lungs. And back then we said that the carbonic anhydrase was in erythrocytes, which is true, but we also have them here in these parietal cells. So we can take CO2, which we make in the cell, because we're using mitochondria to make energy in every single cell. But now instead of taking the CO2 and putting it in the blood, we'll just keep it here, combine it with water, and make hydrogen ion and bicarbonate. Okay, so that's good. We're going to make lots of energy, we're going to make lots of CO2, we can make lots of hydrogen ion, and we'll push it out. Except that we're trying to push this out into the lumen that's already at pH 2.0. It's already got tremendous quantities of hydrogen ions. So there's no gradient to push it from within the parietal cell outside into the lumen. You're going to have to use energy. And we use kind of a convoluted system here because we start by pushing potassium out. So these green ones are going to be potassium channels. And in neuro, we said that potassium's always higher inside the cell, and that's always true. Okay. Well, I should be careful saying always, but that is normally true. So you have high concentrations of potassium inside. If you have potassium channels, this will readily move out into this luminal space. Are they what? Inactive? Like leak?
It's just passive. That's the real question.
Oh, I see. Yes, they're passive. Yes. Yeah, you don't need energy here because you're moving down your gradient. So we'll say these are passive channels. Now you're getting these high concentrations of potassium directly outside. It's kind of why these folds are really helpful. They'll catch the potassium and keep that concentration gradient high there. And we're going to talk about another channel. This channel is going to be a hydrogen, potassium, ATPase. So we've talked about sodium, potassium, ATPases before. We use them in a lot of places. This one is just going to use hydrogen for the cotransporter now instead of potassium. But we're going to use all of this potassium that we've put out, and we're going to move it back into the cell. So now you'll move potassium in. And you can use this to move your hydrogen ions out. Oops, wrong channel. Okay, that's getting a little crazy, but hydrogen ions. So the first step is just to make your hydrogen ion. Then you need to be able to move it out through these potassium, so hydrogen ATPases, but you need potassium outside to do it. So you have these potassium channels that build up a concentration outside that you can use to power this hydrogen potassium ATPase. And then when you do this, you're just going to end up with lots and lots of hydrogen ions outside. Questions on that mechanism? Yes.
So are gasoline concentrations outside of the cell higher at that 1%?
So if you were to look deep into these folds of the parietal cells, the concentrations would be higher. You're still also using ATPase for this. This is not a passive channel. Okay, but you've got a ready complement of potassium there to be able to use for this channel. Yeah. Anything else? Okay, let's talk about then how we can control this. So this is going to be increased whenever we eat. We want to increase the amount of acid that we have in our stomach to help break down that food. So we're going to use a series of GPCRs. Yeah, well, right over there. And we'll start with, not red, orange. Okay. So these GPCRs are going to be on the basilar side of your parietal cell. This first one is going to be a gastrin receptor. So for regulation of parietal cell, number one is gastrin. And this is coming from G cells in the gastric pit. So over here in our gastric pit, we're also going to have G cells. Gastrin is a hormone. Okay, it's not an enzyme that's meant to work in a pH of 2.0. So you don't want to put gastrin into this lumen. It'll just get destroyed. What you want to do is put it out the basilar side and into the blood. So remember we said this was mucosa. We had submucosal layer below this. And in that submucosal layer, you'll have blood. So you can get this gastrin molecule into your blood, and it's going to travel throughout the entire body, oddly enough. But then it's going to come back around It's going to come back out of this blood and bind now to the parietal cell. So that's gastrin. Okay. So gastrin will move out and bind to that GPCR. The second control that we have is going to be histamine. But in this case, the histamine is coming from an ECL cell. This histamine GPCR is an H2 histamine receptor. So we can show an ECL cell here. So again, histamine is a hormone. But we also talked about histamine quite a bit. We know it has actions in different places that have nothing to do with digestion. So we don't necessarily want to put histamine into our blood and have it triggering things in our bronchioles and in our vasodilation. So instead we're going to do a paracrine factor. So this is going to be a paracrine hormone. But even though it's not going into the blood as a hormone, it still needs to go out the basilar side. Let me just specify too, this was an endocrine hormone because it went in the blood. So now you're going to release histamine. Instead of going into the blood, it's just going to go paracrine, meaning it's just going to diffuse locally. So this is just going to come up here and bind. Okay, so this is just going to be diffused, binds. That's everything that's in our gastric pit, all the different cell types and what they release and to where they're releasing them. But we still have one more method of regulation for our parietal cell. And that's going to be acetylcholine. This is coming from a postganglionic parasympathetic neuron. So this is just autonomic regulation. And this is going to be a muscarinic receptor. Specifically, it's an M3 muscarinic that binds that acetylcholine. All three of these are going to have slightly different mechanisms, but the same final effect, where these are going to increase the amount of hydrogen potassium ATPases that you have in your membrane. So when you trigger any of these, from gastrin that got released from your G cells and went through the blood, from histamine that released from your ECL cells and just paracrine diffused over here, or from ACH being released from your autonomic system, all of these will end up with having more of these channels in the membrane, which can then release more hydrogen. Okay, so the end result here is that you're going to increase the acidity in your stomach. So So all three of these mechanisms, the gastrin, the histamine, acetylcholine, all are going to increase those channels and increase your total hydrogen ion concentration. All right, so this is good, mostly if it's working properly, but we all know it doesn't always. Some people end up with way too much stomach acid. Sometimes that stomach acid starts coming back up as gastric reflux. Yeah, I said it right, gastric reflux. Besides actually treating for a problem with an esophageal sphincter, you can also control the hydrogen ions here as well. And there's two main methods of doing this. I don't have space. The first one, the oldest one, is to target these histamine GPCRs, these H2s. So I'm going to try to write it down here. So you've got H2 antagonists, meaning you block those CRs. And by doing that, you reduce the amount or the signals that you're going to get to put those channels, those hydrogen, potassium, ATPase channels in the apical membrane. Okay, these are going to be things like Pepsid, Antagamit. Okay. What they tend to do more of now is block these channels directly. So these hydrogen, potassium, ATPases. They'll not only use an antagonist, they'll actually do a permanent inhibition. Okay, so they'll use drugs that will just permanently block these so that they're not usable anymore, and your body has to take them down and make new ones. And it takes time to do that. So that's why you can take these medications like in the morning and they're still working later, because they're basically just causing these to down-regulate so that you don't have channels to put hydrogen ions out. So that is a proton pump inhibitor. It's what we usually call the hydrogen potassium ATPase. So these are drugs like Protonix or Prilosec. Some of these are over the counter now. Some of these still require a prescription. And of course, there's always the old standby. You can just take some Tums or Rolaids. That's just bicarbonate. You're putting it into your lumen. That bicarbonate is neutralizing all of that acid. Okay. So there's a number of ways that we use to treat this. Okay, the last thing I wanted to tell you is that while we're creating all of this hydrogen ion, we're also making bicarbonate at the same time. So we're going to make crap tons of this hydrogen ion to make our stomach acidic, but now we've got all this bicarbonate. What are we going to do with it? We can't leave it in the cell. There's too much of it. Can't put it out in the lumen because it's just going to neutralize the acid. So we're actually going to move this into the blood. We'll move it out the basilar side and into the blood. But that means when you eat a really big meal and you trigger a lot of hydrogen ion release, you also end up with a lot of bicarbonate that gets pushed into your blood. This is going to make your blood very basic. So we say that after a large meal, you're going to have something called alkaline tide. Meaning that for a few hours after a big meal, your pH is going to be higher than normal. You're more basic. Okay. So that's it for stomach. We'll talk about small intestine tomorrow. Thank you.